So hello everyone, thank you for being here. It's the second shoulder board, and we're going to talk tonight about massive rotator cuff tear with Philippe Valenti, and we have the great privilege of having Christian Gerber, Patrick Donard, and George Athwell with us tonight to discuss 4 clinical cases. And Bassem El Hassan should join us at some point. And Philippe, if you want to start with your case, maybe.
Yes, thank you everyone, and Happy New Year. So I would like to share with you my first presentation. This is a patient of 51 years old. This is the right side. This is a manual walker. And during 2 years, both shoulders, he was painful. And when I saw in consultation, he was very less strength. The range of motion was not so bad, with a forward elevation 150 degrees. And he has no active external rotation. When you maintain the arm in abduction 30 degrees, he cannot maintain external rotation. There is a lag sign, positive lag sign. When the arm is close to body, there is a dropping sign. And when you do abduction on external rotation in 90 degrees, he has a good posterior deltoid, and he has no hormonal sign. So you see that the pain is 8. The function is very bad for this manual walker, is 30%. The constant score is 42. So this is a standard X-rays. You see there is a superior and posterior migration of the head, and a little arthritis of the glenohumeral joint. And this is the MRI, and you see that there is a massive Postero Superior Cuff Tear, and when you analyze the muscles, there is an atrophy of the supra, infra, and teres minor. And this is a degenerative lesion because there is no trauma. He did a plasterer during 30 years. And if you want to summarize this patient, this is a chronic lesion, 51-year-old. There is no trauma, less strength, good forward elevation, but no active external rotation, with atrophy of the supra, infra, and teres minor. So for the audience, we have a vote. And thank you to take 30 seconds to vote regarding what do you want to do for this patient. Do you start with physiotherapy? Do you try to repair the cuff, or only tenodesis of the biceps? Do you propose a tendon transfer because he's a young guy, or a reverse with tendon transfer? And this is the question now for the expert. And maybe we can start with Christian regarding this patient. What do you think about the therapeutic option in front of this chronic, massive Postero Superior Cuff Tear?
Well, for me personally, there would be here the image that you're showing is a little bit maybe too medial for me, could be a little bit more lateral. But so if we are taking the image that is one piece more lateral, then it seems that actually the key issues are subscapularis is absolutely perfect. Subscapularis is normal, has no fatty infiltration, not even of the superior part. Second, very crucial thing for function is that the teres minor is relatively severely affected. On the other hand, there is certainly no changes in the deltoid muscle. For me, with what you are describing, this would be a clear indication for tendon transfer. However, I could imagine that from the views that I've seen beforehand, that it is possible to repair the anterior part of the supraspinatus partly. On this image here, I think that, well, it is very atrophic, but it may be more retracted than infiltrated. If you compare the image of the supraspinatus with the images of the teres minor and infraspinatus, within the muscle there is a little bit less fat. That is usually the case if you have an relatively acute retraction of the muscle, and it may be that the supraspinatus could be partly reparable, which I would certainly try to do for the anterior part. So tendon transfer, I would not opt for in a 51-year-old, despite the fact that he's a plaster. I would not opt for a reverse total shoulder replacement. I think he can be improved. He will probably not regain full strength, normal function, but he will get a usable, pain-free arm with a tendon transfer.
Okay, thank you. George, maybe, do you have another option that, or comments?
So in this gentleman, I don't think we can change the natural history of his shoulder with an operation. I was going to say the cheval, how do you say horse in French, has left the barn. So when the horse leaves the barn, we have time on our side. And so for me, I think what I would start off with is he's got good active forward elevation, he has pain, and so I would start with physiotherapy to maximize strengthening of his deltoid, and I don't think there's any disadvantage in me starting with physiotherapy. And I guess the question is, if he fails physiotherapy, what am I going to do? He's already got high-grade fat infiltration, so he's a candidate for a salvage procedure. So in my mind, if time was of the essence, I'd be a little more aggressive, but because the horse has left the barn, I can be very conservative and then start on the salvage surgeries. And I consider a tendon transfer a salvage operation. It does not return the shoulder to normal. However, it does provide an improved function.
So Patrick, maybe what would you do for this patient?
I agree, Professor Gerber. I mean, I think George's point is well taken, that you don't lose anything, but I just think at a 51-year-old who's high demand and has such a profound amount of range of motion loss, I think this is unlikely to improve with therapy. So I would offer him a tendon transfer. I don't think you can restore that otherwise with a superior capsule reconstruction, for instance, with his external rotation loss. You're not going to, the only way to restore that, I think, is a tendon transfer. So in my hands, that would be a lower trapezius. I do that arthroscopic assisted and try to repair as much of the cuff as I could.
If clinically the patient did not have an external rotation lag sign, but just painful external rotation, but with the same images, would you change your attitude?
If he had preserved external rotation, then I would go for arthroscopic procedure, and I would use an allograft if necessary. The other scenario would be if somebody has an acute injury. Let's say they've had preserved external rotation, they have atrophy, but they have loss of external rotation after an injury. Despite their atrophy, I will make an attempt to repair that arthroscopically, hoping that I can get them back to their injury state. But by that I mean somebody who just injured themselves within 6 weeks and has a clear loss going from having preserved external rotation to suddenly losing that.
So a patient telling you I could put my arm on the side and then I can't.
Right. If they're clear that they could do that before, and I see, you'll typically see edema on that MRI, then I'll make an attempt to repair despite atrophy.
So I guess the question was, Patrick, what would you do if this patient had preserved that external rotation and it's a
Hello, Bassem.
Patrick answered, I think, George.
Yeah, so just to reiterate, if the patient had, usually with this amount of atrophy, they're not going to have preserved external rotation, right? With both teres minor and infraspinatus. But let's say they do, and a scenario where they have slightly less atrophy, like the teres is preserved. Then, if they have preserved external rotation, then I would go for an arthroscopic procedure, and I would use allograft as needed.
I have a question regarding tendon transfer to restore the active external rotation.
I cannot
Do you use Christian Episcopo procedure in this case?
Well, yes, I have used L'Episcopo's procedure. I have used, obviously, I've used a few hundred latissimus dorsi transfers. I have used a relatively small number, but a certain number of lower trap. I apparently do the latissimus dorsi better than I do lower trap transfers. And here the plaster is a person who especially needs good function with the arm abducted in space, and there our experience would suggest that latissimus dorsi transfer is at least as good as lower trap, as opposed to with the arm at the side. If the arm at the side, it may well be that the lower trap, at least according to the reports, restores external rotation a little bit better. Here, for me, I have never seen a patient who had that much infraspinatus atrophy plus actually fatty infiltration, not atrophy, fatty infiltration and atrophy, and teres minor who had preserved external rotation. I've never seen that.
And do you find a difference between lepiscopo and latissimus dorsi? I mean,
well, the way we did, the question is how strong is he in active elevation? There are very few patients, but there are patients where you can restore supraspinatus. If you can repair supraspinatus more or less, then I think that the lepiscopo with both musculotendinous units is probably superior. However, if you do a classical lepiscopo, you are with your transferred tendon, with your vector, you are below the center of rotation of the humeral head, and you antagonize abduction or also elevation. So in very general terms, if I have a supraspinatus, which I do not trust, I really try to bring the tendon up at least to the level of the center of rotation of the head, and that is certainly easier with the latissimus dorsi alone. If you take the teres major with it, then it is very often relatively bulky, has a very short tendon, and it's difficult to attach at the head. If you do it in a classical lepiscopo, you can keep the two together and transfer them to the posterior aspect of the humerus, which works well too. But, I think we underestimate a little bit personal experience with these procedures. I think if somebody who has done 100 lower traps, he's probably better with lower traps. Me, I'm probably better with latissimus dorsi, whether they are arthroscopic or open does not matter. But in this case, supraspinatus or elevation, if I have understood Philippe Valenti correctly, then his active elevation was okay, but it was weak. So yes, I would try to bring the tendon up to the greater tuberosity.
So you still have indications for lepiscopo?
Yes, I have, for instance, indications for lepiscopo in the presence of a reverse total shoulder replacement.
Okay. In the setting of a reverse, you don't have the same antagonistic effect of the transfer of the lepiscopo?
No, I think in very general terms, the external rotation helps elevation. It's a natural aspect of elevation, and I think then the advantage of gaining external rotation outweighs the slight disadvantage of having it lower. Plus, you bring the lepiscopo up fairly high if the head is distalized so much. Here, Bassem, does Bassem hear us?
Bassem. Yes. Can you hear me?
What do you think? Hello. Good evening, Bassem.
Hi, Philippe. How are you?
Fine. And this is I summarize for you. You see Emmanuel Walker, 51-year-old, no trauma. He has a good forward elevation, but he has no active external rotation. And you see that there is a complete atrophy of the infraspinatus and teres minor. On the proposition for Emmanuel Walker, what are you doing?
I will do arthroscopic lower trap. I will do lower trap transfer on this one. Okay. I heard the discussion. I totally agree with Christian when when the infra spinatus has that much of fatty atrophy and teres minor, it will be extremely unlikely for any patient to be able to have any ER. And in my opinion, and my comfort level, I think lower trap will be ideal for this patient.
Okay, thank you. I will give you the result of what I did. It's a patient that I did 8 years ago, and I combined latissimus dorsi transfer on the lower trap transfer. And I restore a good movement in active external rotation, but the patient was not happy regarding the strength. And the patient was not able to return to work. And it is a big problem that for retired is okay, but for manual worker, this transfer is what not enough to restore a good strength to do a big job. This is my the result, and he's not so happy. You see that 60% is not enough for plasterer. And I think that for this kind of patient, I have no real solution, very good solution. For a manual worker with Postero Superior chronic, I have no good solution. What is your comment regarding your experience? Patrick?
I agree with you. I mean, I think that there's some people we just have to tell that, you know, we've done everything we can do for you. And in a guy like this, I would probably encourage him if my tendon transfer is not giving him satisfaction, I would tell him that he can find another job. His pain's not an issue, so I don't think he needs a reverse. I think he has to accept it. And I'm sorry, but there's some people I can't help.
Christian, do you have patients that recover good strength after tendon transfer to a manual worker?
Yes, but not if they have a completely lost teres minor. I've not seen that with complete lost teres minor. You know, I think here is a question of informing the patient. You started with a subjective shoulder value of 30%.
Yes.
You doubled to 60%.
Yes.
With a complete loss of teres minor, with a severe external rotation lag in ab and adduction. So I think your result is probably what you can more or less expect with this operation. Plus, he's almost pain-free. I would have told this patient before surgery that he will need to change profession, or he gets a reverse with a tendon transfer, because he will not get enough strength without the reverse plus the tendon transfer. But I think the treatment is okay. The result is not spectacular, but it is good. It is what you can expect, more or less. You doubled the subjective shoulder value. And I think the main problem of this patient is unrealistic expectations.
Okay, thank you, Bassem.
Philippe, great point. We published twice about the lower trap, the open and the arthroscopic. And again, I have to agree with Christian. I do tell the patient the following. For pain, it's very reliable. It will improve the pain. External rotation, both improvement and strength, they'll improve. I always tell them flexion, you will improve, but the strength is not reliable. And usually I discuss it with them even before surgery. And I agree with you, for patients who have a full loss of posterior superior rotator cuff, I think we can get them external rotation, improve motion, improve pain. The strength, some of them they get, some of them they don't. So they should know before surgery, and if they are okay with it, they go ahead with the surgery.
Just a second, Philippe, how old was the patient again?
51.
51?
51.
So Christian, you have implanted reverses in 50-year-old patients who have good elevation just so that they can get back to manual work?
Yes. Yes.
Okay.
In patients who were
David, you are ready?
really dependent on their income and on their work, who were intellectually not able to be reclassified to a job where they could find work. Usually these are, in Switzerland, these are Portuguese or foreign workers who absolutely have no choice. They have no insurance, they have no coverage, and either they go back to work or their family is in big trouble. So that's exceptional, but as you know, I've been sick several times, and I take any very, very, very good treatment if I think it is good for 15 years. I do not plan for more than 15 years.
So it's a patient that I did not operate on yet. So I don't have any results to show you, but I'd like to discuss with you. She's a 57-year-old patient, right-handed, right dominant, and it's the right shoulder that's affected. She had a car accident 2 years ago, and since then she complains of permanent pain and night pain with limited range of motion. And she lives far away, and so she only came to see a doctor recently, which was me. And when I saw her, she had full passive range of motion, but poor elevation at 80 degrees, poor external rotation, and poor internal rotation. She was very painful with not very good functional scores. But her cuff was painful on most tests, but she had no elevation lag sign, which I learned to describe from Christian, and no external rotation lag sign. And so here are her X-rays. She has no arthritis and no superior migration of the humeral head. And I'm going to show you her MRI. So here is the coronal views. I'm going to show you the axial views. And the sagittal views, hopefully. The quality is not great, but I hope you can see. And I have the sagittal T1. This is the sagittal T1. So I hope you can see. She has no supra, no infra. Her teres minor looks good, and the inferior part of the subscap looks not too bad. And so if we go back to the case, what would you do at that stage? George, maybe, can you help me out?
How's my connection? I
can hear you very well and see you. It's brilliant.
With the, did she have any internal rotation lag signs?
No internal rotation lag sign. External rotation was a 20 degrees and no external rotation lag sign, and elevation was at 80 degrees and no elevation lag sign, but internal rotation was to the buttocks, but no lag sign.
And where's your pain? Do you think it's just generally cuff related, or do you think it could be related to some to her biceps tendon? Is her biceps tendon still intact?
The biceps looked intact on the axial views, but I don't really know how to distinguish cuff pain and biceps pain when I examine my patients. She does not have what I think is AC pain, but it looks more like cuff pain for me.
See, when I looked at, I just got a brief glimpse of the X-rays, and that was a standard X-ray. It looks, I mean, she doesn't have a real prominent tuberosity. Whenever I see that kind of rounding off, I'm always concerned, is that abrasion that's caused that to occur? And so on your coronal MRIs, it looks like that the head is probably eroding up against the acromion. So for me, I mean, I think this is probably, I mean, it's obviously a massive rotator cuff tear, potentially going to be some early onset arthritis when we scope it. But I think for her, I really have to decide between non-operative and physiotherapy. And if it's surgical, I would discuss with her a low yield, low risk operation, which would be a partial rotator cuff repair versus a reverse shoulder replacement. My concern with her also would be that she's had a car accident that caused this. And the way you described that she's having severe constant pain, is there any other issues at play?
Okay, just for the sake of time, I'm going to move on a little bit. So I started by doing some physio because she never had any physio, and a subacromial injection to see how that did. And she improved. So now she has 140 degrees of elevation, which is still not perfect, 30 degrees of external rotation. but she's still very painful. She describes 6 out of 10 on the VAS score, and the scores, the functional scores are still bad. And so now at that stage, what would you propose for her? Maybe Professor Gerber?
Well, the question is whether she is still painful or whether she is again painful. If very clearly, you are at the point where you got to a 60% subjective shoulder value. Constant score is low, but 60% is much better than she was. The question is, how long are you after your injection?
Now it's 4 months after the injection.
Okay, how good was she 6 weeks after the injection?
She was improved during the 3 weeks after the injection, and then she describes a low decline, a slow, steady decline, I mean.
Is she now as bad? She's not as bad as she was before the injection.
No, she feels she's much better, but she's still
then
not
I would
happy with
repeat
her
the
shoulder.
injection.
Sorry?
I would repeat the injection. I think she, in my hands, with the subscapularis, where the upper part of the subscapularis is severely damaged. Supraspinatus is gone. Infraspinatus is bad. So for me, she is a little bit obese, I would think.
She is.
A little bit obese. She's a lady. I would not anticipate that she is, an athlete in terms of willingness to rehab. So for me, she is conservative as long as I can, and then reverse total shoulder arthroplasty.
Patrick?
Yeah, so tell me her age again.
57?
Yes.
57. Okay. I would treat her with a cuff repair at this point. I realize she has atrophy.
Yes, I'm having problem with.
But I think that in my hands, I feel like when the subscapularis is more responsive to repair despite atrophy. I feel more confident in these cases when I have subscapularis involvement that I can get a repair. And I think based on that and the fact that she has preserved function, I think that I would be able to have a good chance of giving her repair improvement with an arthroscopic repair.
So you would repair fat mainly?
I would do a partial repair, yeah. I mean, what you're getting at is you're saying that, well, she's atrophied. Is she going to have good tissue quality and heal? And I'm trying to make the distinction with subscapularis versus infraspinatus. I think the subscapularis is more responsive to repair, and I don't apply the same rules I do in terms of atrophy and fatty infiltration of the subscapularis that I do to infraspinatus.
So you think you can repair something anteriorly, that I can agree with you, but for the supra and the infra, you don't really care what's going to happen, right?
Well, I'm going to make the best attempt that I can, and I think I'll be able to get some repair. I think there's a chance you're not going to get there's a good chance you're not going to get a complete repair, but you're also going to not know completely in my mind until you get in. And then the question, I think, is, do you consider some sort of, allograft augmentation at that time or superior capsular reconstruction? Generally, this is a patient I wouldn't, because in our hands, we've had poor outcomes in patients who have subscapularis atrophy going into the procedure if we attempt SCR.
Okay. And so, Christian, for me, in the setting of irreparable rotator cuff tear, especially in younger patients, the clear indication for reverse was an elevation lag sign, so a true pseudoparalysis. And in a non-pseudoparalytic patient, do you have any other options than the reverse? Is the biceps stenotomy still an option for you, or you directly go to the reverse now?
Well, as I said, I would repeat the injection because
yes,
she has been better. And then I would see, I really do not think that with the superior, actually, just to not be misunderstood, I agree with Patrick insofar as very often the subscapularis is more easily reparable than the supraspinatus. It is also usually less inelastic. It can often be repaired. The question is whether the damn thing heals. And supra and infra, in these cases, fat person, is she a smoker? Do you know?
No, she's not a smoker.
But a woman, I would try to get to a solution which is a solution for her, not a little improvement in that at that age. I think she may be a little bit improved, but then she will come back for a re-repair. And I would go after, really, if she's really not satisfied with a good injection, then biceps tenotomy will not be more than a very good injection, maybe in longer term, but not more. And there I would really go to reverse.
Can I ask a question about injections to the panel?
Sorry.
So can I ask a question about injections? So obviously many of us have backed off the amount of injections we're doing. Do you have a guideline? Because for me, if I'm considering a repair, I'll only do one injection based on the literature just showing that 2 or more injections in the year prior to cuff repair raise the risk for revision. I wonder if anybody else does that differently, or what your thoughts are.
Okay, I can just, because I rose the question of the injections. I use subacromial injections, and I know that everybody thinks that's crazy. I use subacromial steroid injections. I always use 40 milligrams of crystalline steroid diluted in 5 cc's of 2% lidocaine. I never use just the 2 cc's. I've learned that from Jean-Pierre Lyotard, who insisted that you need a relatively big volume so that the thing gets really into all the spaces. Then I do not repeat earlier than at 3 months, very, very minimum, and I do not operate within 3 months of the last injection, and I never do more than 3 injections, never more.
Right.
And
Okay.
I said, I made just to go back to the injections, I asked a very important questions for me to Jean-David. So if you get an injection and then the patient gets very well, and within like 2 or 3 months, he gets back to the point where he was or she was before the injection, I will never repeat. However, if they get really well and then start having a little bit of pain again, but much less that they had in the very beginning, then I try to bring them down stepwise and I do a second injection. So these are about the criteria that I use for injections.
So my use of injections is minimal. I think the literature is well shown the placebo effect is high. I typically use it in patients that have an intact cuff with pain, and I'm trying to isolate whether it's biceps. So trying to rule out impingement syndrome versus a biceps related problem, because impingement I cannot help with surgery, but biceps I can. So I'll use diagnostic and therapeutic injections in those circumstances. And I actually do use it for the AC joint.
So you would inject her in her bicipital groove, this one, for example?
She's got a massive cuff tear, so I'm unlikely to do that. So
Okay.
in patients with an intact cuff, the question is whether they have impingement or a biceps problem, because impingement, I don't operate on impingement. I don't do decompression, but I will operate on biceps and do a tenodesis.
And so to differentiate the two, you inject the groove.
To see if I can help. I don't personally inject it.
But where do you inject? Where do you inject?
I get the radiologist to inject in the biceps groove. So under ultrasound guidance.
And you think that reflects exclusively the biceps tendon?
Well, what'll happen is if they get a local anesthetic effect from within the biceps groove in an intact cuff and it takes away their anterior shoulder pain, I use that as one of the indicators. I think the important thing to realize with cuff pathology and massive cuff tears is there's no consensus, right? We're learning that already. If we talked about Christian wanting to do a reverse, Patrick wanting to do a partial rotator cuff repair, there's no consensus here. I think there's no right answer. We have personal thoughts and experiences, but it's very hard to provide strong evidence that we should do one thing or the other. I think it's back to what Christian said about what tendon transfer he's most comfortable with, and that has a lot to do with how we manage these patients. And I think the audience has to remember that. So for this one, I would involve the patient. I would honestly, as I said earlier on, I'd start with therapy. If therapy didn't work, I would offer her, just as Patrick said, I agree with him with the subscap. The subscap's magical. It could have fat infiltration and you actually get a fairly robust repair. And that can help some patients biceps and a subscap. Or I'll say that's a low risk, low yield operation, more unpredictable. Or I'll give you a higher risk, more predictable operation, which will be a reverse. And I let them decide. I let them make that decision.
But you don't have these patients that tell you, I trust you, doctor, what would you do for your shoulder?
Yeah, and then I'll tell them my opinion.
And so what is your opinion?
In this lady, what I would tell her is that I get an idea of what her activity level is. If she's very sedentary,
That lady, no activity.
then I would probably go along with Christian and say, listen, try to live with this as long as you can. And when you can't, we'll probably do a reverse, which will give you a predictably good outcome. If she wants to maintain more of an active lifestyle, which is unlikely, then I'd probably go towards a partial and hope that we can alleviate some of the pain. Either way, when it's a partial repair, I tell them it's a salvage procedure. There's nothing that I can do to make this shoulder normal like it was when you were young. Everything is a salvage procedure.
Can I just make a little comment, which is, I think, interesting? There is, in Switzerland, there are some legal constraints. And one thing that is very interesting is that what is the definition of an indication? What is the indication for something? What is that? And the legal definition of an indication in Switzerland is, it is a therapeutic approach or a therapy that is taken assuming that it will fulfill the wishes of the patient based on evidence, but directed to an individual. So you cannot say that legally speaking, you cannot say that a supraspinatus, infraspinatus tear is an indication for instance, tendon transfer. It depends on the individual patient. It becomes only an individual patient if that treatment fits to the desires of that patient. That's just a legal point, but I found quite interesting because we try to go towards algorithms, which is something good, very, very positive. But there are patients, very clearly patients, who say, I am very willing to bear this goddamn brace for 6 weeks. And there are other patients who say, you go to hell with that brace. I want the reverse and want to be working in 3 weeks, period. You know, that's my experience. That's the way it is.
Yeah.
And if they are, then I will try to help them. If I think that is really wrong to do it, I will not do it. But if it is within the option, I will yield to the desire of the patient.
I think that's a really important concept. Understand what patient expectations are, and also ask them what their goals are from the surgery. Like, what do they want out of the surgery? If they want complete pain relief, predictably, it's going to be a reverse.
Present the things like this, I think all patients are going to ask for a reverse. Do you want something reliable that's going to work, or something that's low risk that is not going to work?
But it's all on how, as you know, it's all on how you word it. And so
Exactly.
when I do talk about the partial rotator cuff repair, so the advantage is you get to keep your shoulder. You get to keep your bones and your muscles.
But Jean-David, there is one thing that you are missing with that you're making. I think, one question is, if your procedure is a failure, and that may be the case with a reverse, that may be the case with a repair or whatever. The question is whether then the patient is convinced that he had the right operation. If you did a reverse total shoulder replacement and you had an infection for a small rotator cuff tear, then you're going to get in trouble. Even if the patient agreed to have a reverse. So I think we should sort of, and I think George alluded to that, we should look at the worst possible outcome and weigh that into the indication that we try to sort of go together with the patient.
No, I was going to ask you, what is the main symptom of the patient after the injection failed right now? When she came back to you, what are the main symptoms?
I've seen her a few times. She was improving, and now she feels that she has reached a plateau. Her range of motion is not great, and she's still painful at night, every night.
Okay.
6 out of 10.
But you also know in patients that have massive rotator cuff tears, as she does, with relatively preserved motion, you get 150 degrees, their outcomes after reverse shoulder arthroplasty are not as good as patients with cuff tear arthropathy and poor motion.
That's true.
So you have to remember that too.
Yeah, so
She has a very, very, very high CSA. If you want to do something reasonable, shorten her CSA.
What's a CSA?
No?
no, but JD, because in the United States, and I'm not sure elsewhere, I have a number of patients who came to me who had, let's say, no ER or very weak ER, minimal pain, full flexion, full internal rotation, and the recommendation was to do a reverse with tendon transfer. And yeah, exactly. So I think this is very important for everyone from the audience to know that after reverse, if you have full flexion, sometimes you cannot get it after surgery. Specifically internal rotation, many times you lose it. So now you have someone who had internal rotation, who had full flexion, and the ER, if they have no teres minor, many times you do tendon transfer with the reverse is not the best. So now they lost a little bit of flexion, more internal rotation, they get some ER, and maybe the pain is relieved. So I think for patients who have very good flexion and pain is, as what Josh talked about, is different animal completely. You have to be very careful about what to recommend. And what Christian talked about, if it failed, what will be the percussion of it? Because these patients had good flexion, had good internal rotation, but they have pain and limited, let's say, external rotation. And I think we should be wise about what to recommend for them before jumping into reverse shoulder arthroplasty.
I totally agree. I think for the pseudo-paralytic patient, it's always easy. For the external rotation lag sign, it's always easy. But when you have these intermediate situations where the problem is pain, average motion, it's always a problem for me.
But I think
I don't want to put a reverse and have an infection for someone who had okay.
But the question is between Patrick and I, either you believe that you will not be really successful with repair, then you may repeat injection and just wait, or you believe that you will be able to repair, then you should not wait with repair, I think.
For Christian on Patrick, because when you analyze the T1, you have concentration of supraspinatus, spinatus.
We lost him.
There is no possibility to do a partial. There is no possibility to do a partial repair. Repair when the key.
Philippe, we cannot hear you very well.
Have you a coronavirus in your internet?
I think from what I understand is that when the fat infiltration is so high, he thinks that you cannot achieve partial repair. But I think we discussed that. You said for a subscap you can do something. For the posterior superior cuff you can't. But you hope that the subscap and maybe the biceps work that you're going to do will be enough to improve her, right?
Absolutely. You're going to address the biceps at the same time as repairing the subscapularis.
JD, how old is the patient again?
57.
Active?
No, she has her arm is as big as my thigh.
Okay.
Well, I think the key is what Patrick just said, that you can improve her, but you can't make her normal, and she needs to realize that. Right.
Yep.
It's the same with tendon transfers, the case earlier on. I don't have 100% success rate with tendon transfers. We talk about tendon transfers like, oh, that's what we're going to do. In my hands, a lot of times they don't work. And I don't do as many as Christian and Bassem. And maybe it's because of my inexperience, but I've had failures of the latissimus and I've had failures of the lower trapezius also.
Yeah. I have had, if you really want to know about failures, you can ask me. Probably nobody in the world has had as many failures as I have. And the fact is that this is palliation, It's palliative surgery. This is not reconstruction. That's palliation. And you would do, if you go through the whole gamut of all orthopedic surgery, all the palliative surgeries, they improve, whether this is tendon transfer at the hand, at the foot, wherever, they improve. They improve sometimes quite dramatically, but they never, ever restore normal function in a way that you could predict that to the patient. If you say that, That's just a lie. If we go through hundreds of cases, you get very often to like 80, 85, sometimes 90% of normal shoulder function, but normal shoulder is a rare exception.
So I agree with you. You use the word palliative. I use the word salvage. It's a salvage operation that I'm doing. I'm trying to salvage what you're giving me.
Okay.
Philippe,
very
you want to
much.
present your last case?
Yes, I present the last case if you want. This is a very active patient, 71-year-old, and he fall on the left side and with a bike accident. And I saw the patient 1 month after the trauma with not a lot of pain, but a good limited range of motion and no active external rotation. And I will to show you the video of this patient. It's not painful, but I show you the video patient just after the operation.
Just before or after?
Before, just after the accident. It's 1 month or 2 months after the accident. It's not painful, but it was limited in active forward elevation, and it was like that.
Okay.
You see the constant score was 25. The function is 40%, and it was not painful. So this is the X-rays just after the trauma. There is no anomaly. I think that is 71-year-old. It's active. And I did a MRI for this patient. And you see the MRI, it's 2 months after the trauma. And if you want to summarize that, this is a traumatic case, 71-year-old, very active. He does bicycle 3 times a week. He has a 90 forward elevation. And you see that the imaging, I think that is retracted type 3, supra-infraspinatus. The muscles are good. And my question is, what are you doing for this patient? The attendees can vote on the polls, please. Do you propose physiotherapy? Do you repair the cuff? Or do you do tendon transfer or reverse? He's 71 years old, and I would like to summarize and to have your opinion for this active or 71-year-old. Is not so old, I think.
Okay.
Bassem, what are you doing?
Well, for this one, he's active. He does not look like 71, honestly, by the video. This is someone I would repair. I would recommend repair on this patient. He has no ER at all. When he flex, he go into internal rotation. His muscle look great. So this is someone I will repair. I will perform repair on.
And Christian, maybe you have an opinion for this guy?
Same. I would, I would repair. Number one. Number two, it is very surprising the way he elevates his arm, because he at least has an infraspinatus as a tenodesis, and that he elevates the arm like this. I think he has been instructed by you for the video. But I would definitely repair. And if I may add, I have seen a fair number of very large acute tears in elderly persons, which were really acute tears with good muscle quality, and they do, in my hands, they do very surprisingly well, even if they're 2 or 3 tendon tears after direct repair. They are easily reparable, and they do well after repair. So I would not hesitate to recommend repair. I would not try conservative management because you say it's already 2 months. If he had recovered fully, he would have recovered better at 2 months.
Okay. I think that Patrick, you would like to repair, no?
100% agree, and I just want to echo, with an acute tear like this, I wouldn't wait on this person and try to have them go through months of therapy. I think that your best chance of success is going ahead and getting to this sooner rather than later.
Okay. George, agree?
I mean, for me, this patient is a longer discussion than the average cuff tear. The reason is because he's not having a lot of pain, and I'm going to do an operation that's going to cause him a lot of pain. So I mean, Christian's especially tough, but I know most of my patients after a cuff repair, they are painful. So I would.
I'm painful too, huh?
You look so comfortable. No. I mean,
Anybody propose physiotherapy because only physiotherapy because it's only 2 months and do you don't expect with physiotherapy if he has a good deltoid to obtain a good result? No?
well, you know
It's
what?
not a way for you, physiotherapy?
I wouldn't shy away from it. I would offer him 4 to 6 weeks of therapy because if you look at his motion, he's got great glenohumeral motion. He's got a contained, stable shoulder. He's not hiking his papilothoracic joint. I bet you he would do very well with focused physiotherapy.
So, but Philippe,
The
can I ask
question
you?
then
Can I-
The question then is then if he then starts to decline afterwards, have you lost that window to repair him? So if you're going to
Yeah,
do
so-
therapy, I would recommend you do it, 4 to 6 weeks, and then if it doesn't work, then you jump on him and repair him.
So, Philippe,
may I say a word here? The reason, actually what George is saying is very reasonable. One of the key informations that I got, why I would do what I said is he injured himself while biking. So he's a 71-year-old guy who is definitely active. If he injured himself biking, then he's an active guy. So if he was more sedentary, then I think that's quite rational. And we do not know, or maybe one of you can help me, we just do not know which ones of these tears really degenerate relatively rapidly. Here I would be a little bit afraid because on the image on the left top, there seems to be quite a bit of retraction. And if the musculotendinous unit retracts a lot, fatty infiltration occurs faster. That's why I would probably, remain with the repair.
in 70 years old, as we know, many times you get patients who have acute on chronic. You have some fatty atrophy, you have tear, they get acute insult, they cannot raise, but the rotator cuff looked as if it is degenerative tough, that is not acute. If you look at this MRI and you don't tell me this patient 70, I will not know it's 70. His muscle looks great. So for someone like this, if he came, let's say he came 4 months after the injury, he said my arm was not raising well, now it's better, and I look at the MRI, I will even debate still whether to repair him or not, because he's very active, he has beautiful muscles, and I feel someone is worth to give him a chance not to go into fatty atrophy and repair him.
But if he asks you what is going to happen if you don't repair me, what can you tell him?
Tell him the data is not very clear what's going to happen exactly at what time, but for someone like him with retraction, there's a very good chance if we wait several months, it may go into fatty atrophy, and we have examples of such patients.
Okay, I will show you the video of this patient because I decided to do operation. I operated this patient 3 months after the operation, after the trauma. You see that this is a massive cuff tear, and I did a tenodesis of the biceps. And look at the cuff. Look at the cuff. I did tenodesis here with the screw. Look at the cuff. The cuff is retracted at the level of the glenoid, and you see that it's a real trauma because the quality of the tendon is not so bad. I did a little medialization. You see that after release, I reduce, and the quality of the tendon was good. And I did a classical double repair. And I will show you the quality of the tendon. You see that this is an acute tear. And the message was that in the acute tear with a limited forward elevation, you can repair. You can repair because I will show you the clinical result after. I did a double repair without any knots over the tendon, and I use
very nice, very nice.
I use not 7 anchors, but 2 and 5 anchors, Christian. Not 7, because the subscapularis was very nice. And
Philippe, it looks very sexy, very sexy.
And now I would like to show you the result because it's more important that this is the result after 2 years, after 1 year. I show you the same patient. It is the same patient, Christian. You recognize this patient. He's continued to do bike. I think that physiotherapy was not a problem for that. And it's
But he still has to train forward elevation. Huh?
Yes.
Very nice, very nice.
Now, I would like to show this case because I think that in acute trauma, many times, sometimes the patient is pseudoparalytic and sometimes the patient is, and you have to do, to evaluate the cuff and to repair immediately the cuff.
Just a quick question. How did you rehab him for the first 6 weeks? Did you move him or keep him still or pendulum?
No, I don't start very early the physiotherapy. I prefer to put a sling during 4 weeks with passive range of motion, and I start active range of motion after 6 weeks many times, not very early in my experience. I show you. Okay, maybe we have time to do maybe you have, this is I did MRI after the operation. It's interesting, you see that? This is the same patient, Christian. And you see that there is a partial tear here between the supra and infra, and the quality of the muscle is very good. And this is the MRI, post-operative MRI. I did 2 months ago for the shoulder ball.
Very nice.
Okay.
Merci beaucoup.
Maybe you have time. Okay, it's 1 hour. Maybe it's. Do you have comments with this case, Christian or Patrick or George or Bassem?
No.
Key point for the attendees, no?
No?
It looks great.
Okay.
Good job.
And okay, do you have a suggestion for the future, Christian, regarding the case?
No, I just wish everyone COVID-free 2021. Thank you for the invitation. Has been a pleasure to be here, see interesting cases, and be reassured that you're a good surgeon. So.
It's not the problem that I am too old now. I am too old now to do anything.
You have to work hard to become as old as I am.
It's really good. It's really good to see everyone. Really happy 2021. It's very beautiful to see your faces and everyone is smiling. Thank you. It's for a great session. Hopefully, we'll see you in person soon.
Great. So, I think the key is if you ever get injured around Christian, to always say you fell off your bike.
No, I'm not aggressive, you know.
Yeah. He's a Gemini. It's okay.
Did he just say that? I'm not aggressive.
No, I do not want. I don't want people to tell me that they fell from the bike. I don't really. I really think that there are. You know, I really think that this was not a good series to show that, but overall we probably overtreat cases. Overall, surgically, probably overall we overtreat. Not with bad intentions, but I think we overtreat.
So in these acute cases with good muscles, what are the cases that you do not repair, Christian?
Well, you know, the key issue is whether somebody has clearly lost strength without having pain. If I am uncertain, I will inject lidocaine, not steroids. I will just inject lidocaine and test strength. And if the strength is normal, you know, then I will not recommend Retear. Number two, the site of the supraspinatus tear is important. If the anterior part of the supraspinatus is torn, then retraction will ensue. If the anterior foot of the supraspinatus is still attached immediately adjacent to the biceps tendon, then retraction will not occur and you can wait. So these are the conditions. But if somebody needs the arm in space, if somebody wants to use the arm in space, whether that's for writing or working or whatever, and has lost strength, then I will recommend repair in a situation with very good muscle and the supraspinatus tear.
Thank you, everyone.
Thank you, Patrick. Thank you, George.
Thank you very
guys.
much,
See you
everyone.
soon.
Thank you.
Later.
Do that, Christian.